All right, so let's talk about image analysis guidelines. So brief outline of what we're going to be talking about. Why are we doing this? Some terminology, characteristics of an optimal image, and that will relate back to that sheet that I gave you last week that has kind of the checklist of everything. It's like a sheet from a QA program in a department. That's the one. We'll talk about how images should be displayed using forms or measures for looking at analysis, and special situations. So why are we doing this? We want to teach you how to teach yourself, right? If you have learned image analysis appropriately, you will continue to improve as a technologist throughout your career. You'll get better pictures, you'll have lower dose, and you'll be able to contribute to the development of protocols and things like that. Additionally, you're going to start to learn a little bit about pathology. As we do image analysis, we can start to learn about what looks out of sorts. Like, is that positioning or is that actually a pathological condition? So, used to be back in the day, we had positions created for just people, QC, quality control techs, who just sat and looked at images all day long to determine whether or not they were acceptable or needed to be repeated and what impact that had on the workforce. So it also is going to help us determine how to improve. I mean, I think the number one thing that we use this for is, do I need to repeat this picture? We clipped this, the patient's a little bit rotated, is it okay, right? So I'm trying to teach us the criteria to determine whether or not it is okay. So here's a couple of examples of why we do this kind of thing. Just 2 or 3 degrees rotation can affect the appearance of the lungs and the heart. It can also change brightness values along the borders of the lungs on chest x-rays. So the image, let me see. If you look at this image on the left, we can see the left sternal end, the clavicular end of the sternum. So the patient is slightly rotated. And one of the ways that we'll determine whether or not people are rotated is we'll look for that sternal end. Can y'all see that right there? We can also do these measurements of the heart shadow versus a measurement right here, right? Have we obscured pathology? Have we decreased the size of the heart or artificially increased the size of the heart because of rotation? So that sternal end is one of the very first things the radiologists are looking at to determine whether or not the patient's mildly rotated, because that is going to affect how well they can read the rest of the image. So a normal heart shadow, such as this projection on y'all's right, is going to occupy slightly less than 50% of the transverse dimension of the thorax. So we can see this measurement here is less than half of that distance there, right? Versus if I look at this distance here, it's a little bit more. Okay? So, here's another example. We're hoping to visualize the trapezium on lateral wrist x-rays. That's the only time we can see this bone, right? So, if we do not depress and move the thumb to where it's like parallel with with the metacarpal of the second digit, we will not be able to visualize the trapezium, right? So we can see right here real clearly. Let me magnify this just a sec. Here they've appropriately depressed that first digit, right? So that I can see the trapezium. On these other images, it's obscured due to overlap. So, where would this fit in our little PACEMAN acronym? Positioning. We're talking about positioning. The patient was not appropriately positioned, and so now we've obscured anatomy. So also, due to positioning, we might not be able to see joint spaces. We've talked about this some with the knee, right? that if we are not centered appropriately for the knee, due to beam divergence, we can artificially close the joint, right? The same thing can happen on the wrist. So let's look real closely at this. Here's that carpometacarpal, or what is it called again? Yeah, the carpometacarpal, the CMC, right here. So we can see here, we can clearly visualize the joint, right? Because we're centered appropriately. If we don't center appropriately, we're going to artificially close the joint, like right here. So it says the first wrist projection was obtained with the MCs aligned to a 10 to 15 degree angle. The second PA wrist, the projection was taken with the metacarpals aligned to an angle greater than 15 degrees, right? And the third projection was taken with the metacarpals aligned to an angle less than 10 degrees. So we want to be very careful with how we're setting this stuff up. And we're going to be looking at our picture closely to make sure that we're doing that. So we're going to use some different terms, and a lot of this we covered last trimester, right? We need to be thinking about the path of the X-ray beam. So that has to do with geometric factors, right? The angle of the tube, the central ray, right? The focal spot size. If there was magnification or any other kind of distortion due to part misalignment, right? Patient's position. So were they appropriately positioned? Do we need to move things inferiorly or superiorly, right? Caudally or cephalically. Those terms can be kind of interchangeable. We want to be able to visualize a precise anatomic location for the structures that we're looking for. So part of how we do that is we look for bony landmarks. Like yesterday, last Thursday, we were trying to image the sternum, right? What were some of the bony landmarks that we were using for that? Yep, jugular notch or xiphoid process. We can also call it the manubrium notch, sternal angle. All of those things are going to help us make sure that we're appropriately visualizing the anatomic structure, that we're kind of imagining how this stuff is laid out. And then we need to be able to start to mentally rotate this stuff in our mind as we're looking at these pictures to think, okay, is the person rotated too much to the right or to the left, right? That's because it's going to look a little bit different on the pictures. So familiarity with these radiological terms is going to allow us to be more conversant about this stuff, and it will help you understand statements that we're making in class, right? I will probably try to encourage and correct you when you're not using radiologic terminology from this point going on. Do the same to me, right? Because it's easy to lapse in and out. Oh my goodness. This is a good example of what not to do with a slide. Characteristics of an optimum image. An optimal image is going to demonstrate all of this stuff, and this is outlined on that check sheet. This is another way to talk about this is that paceman thing. This is just going to unpack it a little bit to a greater degree. So demographic information, like when it was done, where it was done, what the patient's name was. Markers, correct marker placement. And we want them in the appropriate place, appropriately flipped if possible, and without superimposing any volumes of interest. Okay? All the correct anatomical structures. We want to make sure that we have maximum geometric integrity, so no magnification, no distortion. We want to make sure that we've illustrated radiation protection, and that's going to have to do with setting our appropriate exposure, avoiding repeats, and then shielding. And then best possible contrast resolution with minimum noise. Let me move this up. And no preventable artifacts. Okay? Sometimes artifacts are not preventable. Like I remember doing x-rays on a guy who was a magician. He'd shot a nail through his hand. And the nail was stuck in the meat of his hand. I walked into his room in the ER and he said, "I'm on morphine for the first time." And he wanted me to take pictures of him with this nail stuck to his hand. That was not that was an unpreventable artifact. I'm not going to remove the nail from his hand in order to get better x-rays, right? But it definitely made an artifact on the image. Okay. We want to make sure that our images are displayed appropriately. So before we send them off to PACS, we want to make sure that they're flipped correctly. If they're not flipped, we may need to delete it off of PACS, right, and resend it. Different facilities are going to have different rules for that kind of thing. So I'll just refer you back to what they say at the facility, but the best thing you can do is make sure that it's appropriately flipped, period, before you send it along. So for direct capture, it talks about avoid positioning extremities diagonally on the IR. Does anyone know why we would avoid that on DR?
You have to turn your head.
Yeah, if we're talking about doing direct capture and we've got like, and we're trying to do a forearm and we've positioned it diagonally across the imaging surface, right? It's going to be very difficult to appropriately rotate it to send it to PACS because we've directly captured it like that. It's going to be, in our PACEMAN acronym, it's going to be unesthetic. It's going to be just a weird, wonky angle. Now, there's going to be times when we can't avoid that, but we're going to try to avoid it as much as possible. So we want to make sure that we're aligning things to either the long axis, so like the y-axis, or the x-axis of our image receptor, okay? Because we can't turn it very much. So here's an image that, this is kind of an interesting image. When it was taken, it's being poorly projected in the PACS system or electronically. It's upside down on the image to the left. The marker's appropriate, right? The marker's appropriately displayed. It's not on the correct side, but it's right side up, right? It's not mirror imaged. So the tech determined they needed to flip this along the long axis and then flip it again over the short axis, right? So the image on the second image, they flipped it along the long axis, and then the third image, they flipped it again, and now it's appropriately displayed. So inaccurate display can make for confusion both for the technologist and also for the doctor who's having to look at this picture. Fortunately, the marker was appropriate. This is a right marker, so I know that that initial image is not appropriately displayed. Okay, this is a little bit difficult to see, but we can sometimes apply a contrast mask here. Who can see what the difference is between these images? What's going on with the image on, what's different about these pictures?
The iliums aren't symmetrical.
The arm, right? This one has, the one on the right, they've applied a contrast mask to obscure this detail over here. You can actually see the border of it right there. You can see the border of it right here too. They've done that in order to aid the physician with better visualizing things in the darkroom. The problem with that is once it's sent to PACS, if it's sent to PACS like this, even though the exposure was done like this, we've obscured diagnostic information, like it's stuff that was on the original image. So if there was like a osteoblast or a cancer that was apparent on that humerus, right, like an incidental finding, and the radiologist doesn't have that in their report, it was in the initial image, right? Yeah, it removed their right marker. It's a good eye. So the best thing that we can do to avoid that is just take the picture correctly collimated to begin with. So these kind of post-processing manipulations have become increasingly common in the workforce, but if we're honest, it's just laziness. Like they're applying image analysis at like the CR workstation. They're kind of clipping the image to make it look prettier when they should have been doing that from the beginning, not at the CR workstation. They could have done that when they were initially lining things up. Like if you watch those technologists, this is kind of my conundrum, and I think y'all might share this. Those technologists that are rushing you along, they're not collimating, they're not asking the patient to breathe appropriately. How much time are they really saving if they're then adding masking and clipping stuff and adding markers at the post-processing point? All they've done is decrease their time with the patient, which doesn't do anything to help them or the patient, and they've increased the amount of time that they have to spend on the back end correcting stuff, right? So there's an amount of time that each thing should take, and if we kind of budget our time appropriately, we'll get good pictures. Okay. So this, I would say, is one of the number one difficulties that we have with telling whether or not we've got an optimal image. The number of pixels that we have at our display stations, it's totally out of our control, right? When we're looking at a monitor, it is not as high a resolution monitor as the radiologist monitor typically. Some places they have 2K monitors at both places, but that's pretty rare. So what you're seeing before you send it to PACS is less resolution already than what the radiologist is seeing, right? So a lot of times what we do is we turn down the lights, we try to decrease the amount of image, like light pollution or light noise in the area so that we can better visualize what it is that we're looking at, right? But ideally they would just go ahead and buy us nice monitors and nice ergonomic places to look at these pictures so that we're not uncomfortable and like sitting at some funny angle in a really noisy room while we're looking at our pictures. So once we've decided that this thing is correctly projected, then we can start to look at the picture really closely to determine if it has all of the criteria that we want for an optimal image. So it's best to be fairly systematic with this. That's why acronyms like PACEMAN are helpful. It brings us through a little checklist, a little mental checklist. Is it positioned correctly? Yes. Do I have all the area that I need? No. Is it collimated? No, I didn't collimate it right. Going down that checklist will let me determine if I've got more than 2 or 3 of those things out of whack, maybe even just one of them if it's critical, I probably need to repeat the picture. So that's why we use forms, or we used to use forms some more, not as much. So here's an example of the form that I gave you. Just be aware that this is a pretty exhaustive form, and it'll be helpful in guiding kind of our. So, demographic requirements, as we mentioned before, we want to make sure that we've included the patient name, that it's correct before we send it to PACS, so that the numbers are correct. Every now and then different PACS systems kick out funny numbers and stuff. We want to make sure we do all of that before we send it, because again, that can save us some time and make sure that there's no overlap. So, here's a marker that's been placed digitally after the fact. You can see, yeah, right up here, they had the marker, but it was not fully in the collimated area, right? Honestly, it would have been difficult to place the marker in the collimated area. So they at least got it a little bit in the corner there, and then they added a digital marker after the fact. It's appropriate. So, general guideline, when we're positioning the volume of interest, the area that we're trying to image on the image receptor, the long axis is aligned with the long axis of the image receptor, and it's going to be tightly collimated. So, the actual area of the image receptor that is needed to include the required anatomy is defined by accurate central ray centering, right, and good collimation. So, the very first thing that we're going to be able to see when we look at this picture is kind of a foggy idea of where the center point is on the image. That should fairly well align with where the central ray was directed. So that will let us know whether or not how the geometry works from that point on. So, a volume of interest can, when we're working with a DR system, a volume of interest can be placed anywhere within the image receptor without reducing spatial resolution or causing histogram analysis error. What the heck is that talking about? What it's saying is, if I told my Fuji CR reader, right, that I just took a hand x-ray, but it's off-center, the hand x-ray is off-center, nevertheless, the hand is somewhere on the CR plate. When it reads it, it's going to still be able to apply its histogram overlaps to that information. It is still going to be able to correctly interpret that volume of interest. It's just going to shift its histograms over a little bit, right? Until it finds where that volume of interest is. So that's why with long bones we can place them diagonal to the image receptor. So when I said earlier, don't place the long things diagonal to the image receptor, that has simply to do with display. Now that we're talking about like anatomic structures and how the things are actually processed, it's not going to affect the processing. It's prepared to apply the right histograms to that. That's how the computer does what it does. So it's not advisable, but it can still work with that. This here says it may result in a poor exposure field recognition and a histogram analysis error. One of the things that we can do to help the computer at that point is to crop if necessary or to collimate appropriately, right? To help the computer find what it's looking for. So here's an example of what we're talking about here. On the left side we have a forearm. On the right we're showing imaging of leg where we've had to place it diagonal to the image receptor. Okay. As a general guideline, each projection should demonstrate a small collimated border around the entire volume of interest. So the only time this rule doesn't apply is when we need to use the entire image receptor, right? It's helpful to learn to use this collimator guide that's normally displayed somewhere on the tube, right? It can tell you some helpful information about exactly how the area is that's covered, how big that area is. And it's helpful too, because of the way this beam geometry works, to be confident that the IR is sufficiently covered, even though if the little window of light looks small on the patient's back. We know that because I looked at the collimator guide, it is sufficiently covered that magnification and divergence of the beam is going to account for the final say in that. Does that make sense? Do you understand what I'm talking about here? Okay. We can move the collimator. So here's an instance in which if we left the collimator in a normal position, kind of perpendicular to the floor, we would unnecessarily expose the patient's thyroid and practically up to their eyes because of their kyphosis. So we've turned the collimator and coned it in order to kind of clip out some of that unnecessary exposure. So same image receptor size, we've just turned the collimator. So kind of along with that idea of beam divergence, if the shadow is not cast on the image receptor, then we will not be able to see it. So they came pretty close right here, right? Even though the thumb looks like it's a good ways from the margin of the collimated area, the shadow, the central ray is right here, and so the shadow is being pushed out. This happens on a lot of stuff. So we want to make sure that we allow the collimated field to be open enough so that all of the object is included. even the shadow of the object. So, these anatomic relationships, we spent a lot of time talking about this last trimester, but a lot of what we're going to be talking about this trimester is positioning routines, understanding why we have these routines, and what the procedure is specifically done for, making sure that the anatomic relationships and the positioning procedures are lining up, being able to identify important structures on the images. So we're not expected to read these images for pathology necessarily, but we do need to make sure we have all the correct anatomy. If it's off center, if it's angled, if it's magnified, foreshortened, any of that stuff, we need to be able to identify that. And we ought to be able to guess at the degree of obliquity that the patient is rotated to. So is that like a 15-degree rotation or a 45-degree rotation? And then know whether or not all the appropriate, like, is this an appropriate amount of flexion or extension, or are all the joint spaces visible? So that's a lot of the stuff that we're looking at when we're evaluating these things for the area that's covered, the anatomy that's covered. Okay. This is from a technologist point of view, working in the clinical site. This is probably the number one reason why we do image analysis right here, is determining whether or not we need to do a repeat exposure, right? So here's a few things that we can be thinking about. Are there at least two structures that are mispositioned because of the way this exposure was done? We can measure, we can use little measuring tools or just kind of guesstimate the degree to which the mispositioned structures are off. Try to figure out what will move them back into alignment. Does the patient need to be turned to the right or to the left? And then we will begin, typically it helps to work methodically, right? So we'll begin with the very first thing that was not quite aligned, and if we need to go from there, we'll go from there. And bear in mind, as you turn one side, the other side's turning as well, right? So normally you have to go about half the distance because you're meeting it in the middle. I apologize for this. It shouldn't appear like this on Moodle. So if we need to reposition the central ray, we're going to determine the structures that are farthest from the image receptor, because that's going to be what's going to overlap, right? So if we're doing an APD and we didn't align the central ray correctly and the joint space appears too closed off, we're going to determine which side is overlapping and in what direction. So what we know is furthest from the IR is going to be like the patella, right? The front part of the knee, the anterior surface of the knee. And then we're going to determine the number of inches or centimeters to which we're off. We can apply measuring tools from the CR workstation or from the DR workstation. We should have some measurement tools at our disposal. And then we will estimate how much the structure situated farthest from the IR will move per 5-degree angle adjustment placed on the CR. So if we determine that regardless of how I move the central ray, because of the patient's size, the knee is kind of kicked up at an angle, I can start to visualize how I might actually need to move that central ray cephalically, like the angle of it, and to what degree. Does that make sense? Okay. When we're looking at the sharpness of the images, this is another thing that's severely limited by the monitors that we are using. We need to, because the amount of sharpness, the degree of sharpness that it's showing us on the monitor is limited by the pixel count of the monitor itself. So, but this is going to relate to the clarity of the anatomical lines that are displayed. And it's measured by the degree of blur, right? if we're just talking about, if we remove ourselves from the monitor and the amount of resolution from the monitor and we go back to the actual imaging process, the exposure, the things that are going to affect that, right? Like on film, if we're talking about film, it's going to be the focal spot size. Was it large or small? Was it appropriate to the size of the anatomy? The distances. Is there an increased OID, right, that's causing magnification and loss of resolution due to magnification? Was there patient motion? Was it involuntary motion or was it voluntary motion? What would an example be of voluntary patient motion? Moving their arm, not listening to breathing things. What would be involuntary patient motion? Heartbeat, farts, right? Any kind of action within the digestive system. And then finally, the actual spatial resolution of the crystal material that composes either the CR or the DR. So how well can these crystals pick up on details? How well are they representing what we're projecting as ones and zeros? Are they little tiny ones and zeros or are they really big ones and zeros? If they're really big ones and zeros, we're going to lose some spatial detail. We're going to lose some resolution. And we'll dig deeper into that next week. So here's some special imaging considerations, right? We need to practice radiation protection. We've kind of beat this. This is a dead horse now today, right? But that means we want to prevent any kind of, we'll definitely prevent any kind of threshold dose, and we just want to limit radiation use to beneficial uses of radiation. We don't want to have unnecessary exposure. That can also, and the big part here goes back to, like we practiced this morning, effective communication, telling the patient what we're doing and why, giving them the information that they need to cooperate, right? Helping them by immobilizing them, and that can be anything as like telling them to lean against the chest, the bucky for a chest x-ray, or giving them one of those bars for the lateral, right? That would be assisting them with holding still. Increasing the source to skin distance as much as possible. We should never go closer with diagnostic x-ray, we should never closer than like 38 inches from the patient's skin surface, right? Minimizing any kind of exposure to unborn children, and then making sure that we're practicing gonadal shielding appropriately. So here's another way of using the collimator to prevent unnecessary exposure. They've applied a gonadal shield. It's just probably a lead strip over this image. They didn't want to change the collimator angle because they wanted to make sure that they had adequate penetration of the part and that they were able to visualize all of L5. So rather than turn the collimator, they just applied a lead shield to the area that they're trying to avoid exposing to radiation. Here are appropriate uses of gonadal shielding for female and male patients, right? Not a lot of places do this. We don't see this a lot. But if we look at our chart of BERT exposures, a pelvis x-ray is a pretty high amount of x-rays for diagnostic x-ray, right? So if we can figure out ways, if there are policies and protocols that we can put in place to do this, if we're just wanting to rule out, because all we're interested in these images, like on the image on the right, is all I'm interested in is their hips. I'm not going to gain any information from seeing that soft tissue there. So if I can avoid clipping the bony anatomy and protect the gonads of this patient, that's appropriate. But again, This is stuff that we would need to vet to the department, right? We just got a couple more. So, radiation protection means shielding the radiosensitive cells that are not within the primary beam or that are not relating to the diagnostic value of the exam. Using appropriate collimation, collimate, right? If you forget everything that I say today in class, the one thing that kind of unites both this class and radiation protection, radiobiology, is probably collimation, right? It's going to get us prettier pictures. It's going to be less of an exposure to the patient. We want to use appropriate exposure factors, especially if we're using a CR unit. We know about dose creep. And then automatic exposure controls, the backup timer should be appropriately set. Right? Anytime we're using an AEC, we should know what that backup timer is set for. Okay? So, avoiding dose creep, avoiding anatomic artifacts, like we see this a lot in surgery, where the surgeon's putting the anatomy out there. He's got his hands right in the area that we're trying to take an image of with the C-arm, right? So now we've got overlap of anatomy. I've obscured part of the distal phalanx of the first digit with this joint here. And I'm also obscuring things here due to overlap. And I've unnecessarily exposed someone's hand, right? And then also being aware of who is in the room with us. Are there family members with us? Okay. Questions about that? All right. Let's take a 5-minute break.